Sara Van Driest, who's a PI on the MPRINT CET at Vanderbilt University. And she's going to be talking today on using real-world electronic health records data for precision medicine research.
Great, thank you so much. Thank you for your patience as we got things figured out. I'm going to take my mask off since I'm alone in a room now. And let me see if I start video, you guys can see that I'm not Jim. So it's great to be here. I'm really excited about the MPRINT network and the work that we're going to be able to do collaboratively, both within the network and as the network reaches out across lots of sites. And as we build this into, because it is something new. So the team asked me to talk a little bit about real world data, because it's an important edge to our MPRINT network, and how we can use this for precision medicine research. So that's what I'll be talking about today, using some examples from my own research passion, which is pediatric pharmacogenomics. So next slide. Great, and by way of disclosures, I am going to talk about real world data, which is hard to pronounce, so I'll call it RWD. That comes from electronic health records. I'm going to talk about examples from proton pump inhibitors and fentanyl, which are often used off-label in children. My funders for this work are shown at the bottom of the screen here. And then an important disclosure is I'm going to talk about RWD. I'm going to talk about modeling and pharmacokinetic modeling. I am not a modeler. I am not an informaticist. So I'm a pediatrician and a pediatric researcher. So that's the lens that I have, and I defer expertise in those specific areas to others. And I'm really lucky to collaborate with awesome people in those areas. And there are some awesome people in those areas on this call as well. So we can have a great discussion if I talk fast enough for the next half hour or so. Next slide. So specific objectives for this talk include, talking about some examples of RWD, as I mentioned. And really the goal is to illustrate the potential utility for these data to build evidence for pediatric precision medicine. But also, I think, and equally important in my mind, is to demonstrate some of the challenges of real world data, because it is not a simple out of the box solution to answer every research question we come up with. I am a simple scientist, as shown in this cartoon. I am not a rocket scientist, and pharmacogenomics is not rocket science. I think you'll all be convinced of that by the end. It is something you have to gain a little bit of wisdom about as you use these types of data, though, so that your rocket doesn't end up looking quite like that one in the picture. So next slide, please. When we think about electronic health records, some people see something like what's shown in this picture here. And depending on who you are, you might see very different things. Some people see a piece of junk, and the electronic health record is like a necessary evil. Like it maybe gets you from point A to point B, but you're pretty disappointed about how it does it. And it's a thorn in your side. Other people look at this and say, oh no, this is a diamond in the rough. This is something that can be really helpful. And maybe there's more to it if we look under the hood. So if you, next slide. So it turns out there's some really powerful stuff in the electronic health records that we might be able to use if we use it appropriately. But it is really important, like I said, to look under the hood to see what's there and to understand what you're getting into, because you're almost as likely to open the hood and find a rat's nest than you are to find one of these pretty motors that can get you from point A to point B, like I said in your research questions. Next slide, please. So how can we build evidence for, let's see, it looks like did we skip one slide, Sarah?
No.
Okay, sorry. Thank you. So this is just, sorry, this is my outline slide.
What, the next slide?
Yeah, let's go ahead to the next one. Perfect. So pharmacogenomics is the using of genetic data in order to get the right drug, the right dose for our patients. And at Vanderbilt, we've been doing this for a really long time as part of clinical care. The research has been going on for decades, but in 2010, we had a newspaper article about how this patient, Sybil Van Cleve, was benefited from pharmacogenetic testing to get her on the right antiplatelet drug after she had a heart attack. So next slide, please. My favorite quote from this article is that Sybil said, there's nothing normal about me, when she found out that she was a CYP2C19 poor metabolizer, and thus she needed a different drug instead of clopidogrel in order to prevent a thrombosis in her case. Next slide. What's sad though, this is my very saddest pie chart in the world, is that almost all of our pharmacogenetic testing at Vanderbilt is done in adults, and very few pediatric patients benefit from this approach because they're just not tested. Next slide, please. One of the reasons why we don't do as much pharmacogenetic testing in pediatrics is because we use a different set of drugs. So these are the CPIC level A, or drugs that have really good pharmacogenetic associations with them. These are the drugs, or the exposures in pediatric patients at 15 different health systems. So these data were curated through the IGNITE network, and they represent about 3 million patients per year. And you can see clopidogrel, that drug that Sybil Van Cleve had pharmacogenetic testing for, is in the blue line close to the bottom, with fewer than 50 per 100,000 patients per year exposed to that drug. It's just not a drug that we use for pediatric patients. On the other hand, there are some drugs with good pharmacogenetic association evidence that we do use a ton in children. So ondansetron, the analgesics, formerly codeine, and now things like oxycodone, et cetera. And then in the hazy red line there are the proton pump inhibitors. That is a drug that, when we collected these data, was not yet a CPIC level A drug. It was one that we had some early evidence that we thought it was going to elevate to that level eventually. We had some initial signals that there was a pharmacogenetic story there. It's very commonly used in children, often appropriately, also often inappropriately. But it's one that we think that we could do better with kids if we had good pharmacogenetic evidence. But there are pieces of that evidence that were lacking. So next slide, please. So what do we know about proton pump inhibitors? Well, we know that they are metabolized by the cytochrome P450-2C19 enzyme, some more than others. So rabeprazole is mostly CYP3A4, whereas the other proton pump inhibitors listed on the slide there are mostly CYP2C19 substrates. They're inactivated by CYP2C19, so the functional level of that enzyme in any one individual determines how much drug you have available. So CYP2C19 is a gene that is highly polymorphic, meaning that within the population, people have very different functional levels of this enzyme. Everything from poor metabolizers that have no function whatsoever. This isn't associated with disease or not being a healthy human being, as Sybil Van Cleve demonstrated for us, all the way up to ultra rapid metabolizers that have actually increased CYP2C19 expression and can really chew up this drug. Next slide. So we can imagine what's going to happen if you have a proton pump inhibitor and you have increased CYP2C19 function. You might have low concentrations of the drug and decreased efficacy. And on the other end of the spectrum, if you have decreased CYP2C19 function, you may have high concentrations of the drug and increased toxicity. Next slide. So what do we think about with this? With decreased efficacy, we think, oh, they might still have symptoms, still be generating too much stomach acid. Next slide. And with increased toxicity, one of the things that we worry about with proton pump inhibitors is there may be an increased risk for infection events. Next slide. At the time that we started this research endeavor, again, a few years ago now, we also knew that CYP2C19 metabolizer status affects the pharmacokinetic attributes of this drug in adults. So we saw differences, basically, depending on which drug. You can see here rabeprazole, the differences were less significant, whereas for omeprazole and lansoprazole, we had very different AUCs for these drugs based on whether you are rapid, intermediate, or poor metabolizer for CYP2C19. Next slide. Now on the pediatric front, we also saw that CYP2C19 metabolizer status had statistically significant differences in the AUCs for various proton pump inhibitors. So again, the poor metabolizers have higher exposures and the ultra rapid metabolizers have much lower exposures, shown here for pantoprazole and omeprazole. Next slide. Do these pharmacokinetic differences, though, have a clinical significance when it comes to our patients that we're treating and trying to suppress their acid in their stomach? This is a big question because it depends on whether or not we're actually, entering and exiting the therapeutic window by having these different CYP2C19 activities. So this was a really interesting study that was done several years ago where they actually had pH probe data for patients that were treated with proton pump inhibitors. Next slide. I think I've got some animation here. Yep. So we've got carriers of CYP2C19 star 17 that made them rapid metabolizers. Those individuals, thank you, had a difference in their time with their pH less than 4. So this showed us that these individuals had less effective therapy with proton pump inhibitors than those that had slower CYP2C19 activity. Next slide. Another angle of clinical significance came from looking at some data that came from a, sorry, go ahead and click through the animation on this one. Thank you. That came from a randomized trial looking at asthma in children. And in this, they had excellent data on infection events. It turned out in this randomized trial, proton pump inhibitors were not very helpful in treatment for asthma. There was a time when that was a good hypothesis. This trial showed that that was not very effective therapy. But they had metabolizer status for CYP2C19 from each of the participants in the trial, and they had infection events. So they went back and looked amongst those that were treated with the proton pump inhibitors, and they actually did find that the poor metabolizers had more upper respiratory infections, sore throats, and other adverse events than those that were extensive metabolizers, which is an old term that we use to describe normal metabolizers. So again, this gave us a hint that there was potentially a clinical difference, not just a pharmacokinetic difference for proton pump inhibitors in children. Next slide. So working with Tiana Bernal, who was a pediatric GI fellow in my lab at the time, and my research assistant, Ida Aka, we set out to see if we could validate this drug-gene interaction that had been seen, specifically thinking about these adverse events in pediatric patients. So next slide. So what we used to do this was the BioView resource, which is an electronic health records data resource, where the data from the electronic health record are de-identified to create something that we at Vanderbilt call the synthetic derivative. You can think of this as kind of a mirror image of the electronic health record that contains information on over 2.5 million individuals. Next slide. These data are coupled with DNA from discarded blood samples for individuals who have consented to be part of the biobank, and this is called BioView. BioView contains over 240,000 DNA samples, over 30,000 of which are pediatric, and those DNA specimens, and eventually as they're genotyped and as they're assayed, the genetic data actually live here on campus and are available for research. And importantly, the information from the electronic health records are coupled with that genetic information so that we can do cool studies like pharmacogenomics. Next slide. So we needed to define the cohort and the outcome. And so we did that, the cohort definition in an algorithmic way, because again, we're starting with millions of individuals. We needed to whittle it down to those who had exposure to a proton pump inhibitor at the right age. So we were interested in children 0 to 36 months old. We wanted to make sure that we had good follow-up information. So we required that we had multiple billing codes in the chart for each patient for the years that they were on therapy. And by using this strategy, we had a cohort of 670 individuals. Next slide. We also wanted to collect outcome data in a way that was algorithmic. Although Tiana was willing, as part of her fellowship project, to just read records for 670 patients and count how many times they had upper respiratory or GI illnesses, we thought it'd be much better to do this in a robust and standardized way. So what we did is we came up with all the billing codes for these infectious events. And then we required that you have at least 14 days between infection events, understanding that sometimes a pediatric patient may present to a provider multiple times for the same infection, perhaps at the beginning, and then when things get a little bit worse, and then perhaps for a follow-up visit. So we were able to use these codes to make these, define these infection events when we started counting them 7 days after the start of the proton pump inhibitor, and we observed each patient for 12 months while they were on the PPIs. Next slide. An important covariate to include in this analysis was the proton pump inhibitor dose. Again, we're extracting all these data retrospectively from the electronic health records. Now, I knew that there was a table that had already been generated by our electronic health records de-identification team that had details for each of the meds. And I thought, oh, well, this should be relatively straightforward. We can just pull the data from this table and we should be in good shape. But unfortunately, when we looked at the table, it was like this. It was like mostly blank. Like it had some strengths, but it didn't have amounts. Like we couldn't tell how much these patients were given. And this was because these tables were generated with adults in mind. Not surprisingly, there are a lot more adults than children in the biobank and in the EHR. And so it doesn't do well with liquid medications. It doesn't know how to calculate those. Next slide. So what we were looking at was tens of thousands of records with medication dosing information that are that looked like this, where we had the medication name and either a tablet amount, but then direction to take a quarter tablet daily, or we had these liquid solutions that they needed to calculate based on the concentration. These are relatively easy calculations to do, but time consuming. As I mentioned, we had over 10,000 entries to sort through for our cohort of 670 patients. Next slide. So this is where it got fun, because I got to work with a couple of collaborators in bioinformatics who included Dan Fabry and Joseph Coco, and they had developed a crowdsourcing platform for exactly this kind of thing. They had a small army of people like medical students, nursing students, other pharmacy students, other people with a little bit of medical training who are ideally suited for this kind of task. And we lifted the text from those notes where we had the medication dosing information and threw it in this crowdsourcing platform and gave them a little calculator and went ahead and asked them to calculate it for us. And then we paid them a fraction of a penny for each of the calculations that we did. We had multiple individuals code each patient's data, and then we were able to check the concordance after that. We did not get perfect concordance. We got 75% concordance on those for the specific doses that were calculated, but it significantly reduced the amount of work that we had to go through in order to get the dosing, which was really helpful. Next slide. So this is the final table one that describes the cohort from this study that's now been reported. And as you can see, there are 670 individuals with a median age of 7 months. And it's a relatively high number, a high fraction with various comorbidities, because these are the patients that are treated with proton pump inhibitors, particularly in the setting where I am, which is a children's hospital, which is a referral center. Next slide. There we go. So in terms of infection events, which is our primary outcome, what we found is that there was a difference in total infections when we looked at the rapid metabolizers versus the normal metabolizers. We didn't see a significant difference between the poor metabolizers, which I think was because of a small number of patients in that bucket. On the univariate analysis, it was significant. And actually on the multivariate analysis, where we did adjust for the common comorbidities that were associated with these outcomes as well, it actually became more significant. We found that the rapid and ultra rapid metabolizers had a lower risk for infections, which made sense because we thought that they had lower exposures to these drugs than the normal metabolizers. Next slide. So what we learned from this study was that this previously observed difference in PK due to the variable CYP2C19 metabolism did appear to be clinically significant for children, at our tertiary care children's hospital. that we might need to titrate doses to balance efficacy and toxicity of PPIs for kids. And then I think more importantly, this study really provided information that proton pump inhibitors may be associated with increased infections in children. I think there are a lot of pediatricians who use these drugs with a lot of liberty, sort of thinking that there aren't side effects associated with proton pump inhibitor exposure. But what we showed is that genotype, something that should be not associated with, and it wasn't associated with infection risks, it wasn't associated with risk for these comorbidities and whatnot, that what we saw is that we saw differences by genotype. And so that showed that this drug is really causing an issue for these patients. For a totally healthy patient who has maybe one extra upper respiratory illness in a year of proton pump inhibitor therapy, that may be worth it. For a patient, if you're treating something real. For a patient who doesn't need to be on the medicine at all, it's inappropriate, then that's just risk without any benefit. And for high-risk patients who maybe have a propensity to have a bad outcome from something like an upper respiratory tract infection, like those kids with congenital heart disease, congenital lung disease, we need to be thinking very carefully about these drugs because they may set them up for higher risk for infections. Next slide, please. There are limitations, of course. This is a retrospective study. We're going to talk more as we move forward about data quality. We were also limited in our data quantity. As I mentioned, we had a big study, but still didn't have a good number of poor metabolizers to look at. We know that we don't have complete ascertainment of infectious events. If the child was kept home by their parent or guardian and didn't seek medical care, we wouldn't have that information. Or if they went and got seen by a provider that was outside of our system, we wouldn't have that information. Again, we wouldn't expect those things to be different based on genotype, but it's something that we are very careful about in our data. And then these data provide us that information about the fact that this difference in pharmacokinetics is clinically important. It doesn't tell us what the right dose is for kids. So that requires a totally different kind of study. Next slide. So this study was published in the Journal of Pediatrics. And again, I think the interest came as much from the fact that we're finding a side effect from proton pump inhibitors as the genetic association. Next slide. It had a helpful editorial that went with it. Next slide. And the editorial points out that we need to consider that there is an increased risk of infection. And I appreciated that the editors, or the folks who wrote the editorial, also commented that this provides some insight into the power of linking databases with outcomes like infections with things like genotype, which of course is one of the things that we hope to do in MPRINT, is to help make these linkages across even single institutions to multiple institutions to increase our power to be able to detect these kinds of associations. Next slide. These data were incorporated into the CPIC guideline for proton pump inhibitor dosing, and those guidelines do recommend dosing changes based on CYP2C19 genotyping, depending on which proton pump inhibitor you're considering. Next slide. All right, so I'm going to switch gears a little bit now. Let me ask, since I don't have a good view into the chat box, whatnot, Sarah or others, are there questions specifically about the proton pump inhibitors I should address before I move forward?
If I can unmute, I can tell you that. Yeah, there's one specific to the proton pump inhibitor. Was there a relationship between the dose of proton pump inhibitor and the incidence of infections?
That's a great question. We actually didn't find in a univariate analysis, we didn't see an association of dose with the outcome, but we did for the metabolizer status. So that's a curious thing that you have to think about a little bit. One possibility is that the providers were adjusting the dose a little bit, or not adjusting the dose enough. So everybody's sort of on the same dose, and so rather than titrating it up or down, very standardized dosing being given. Another is that that was being done, but not captured in the EHR very well, so that we couldn't see the impact. Because, you know, if things were happening like on phone calls or in visits, and the provider wasn't making an annotation in the electronic health record to increase the dose, then we wouldn't have that information. So it's absolutely a limitation of what we did.
And another question relating to the study, did you evaluate phenoconversion possibilities?
For this particular study, we did look for CYP2C19 inducers and inhibitors, and they were exceedingly rare in this cohort. We just didn't, our patient population was not exposed to those drugs at the same time as their PPIs. But that is absolutely an important consideration to take into account in general for pharmacogenetic studies.
Great. Yeah, I think the other questions in the chat have to do with ethical issues in IRB, so maybe we can wait until the end of the talk to discuss those.
Sounds good. So the second part of my talk uses a different example. So we're going to talk about fentanyl pharmacokinetics. And for this, we can go ahead and move to the next slide. The general theme of many pharmacogenetic studies, including the one I just talked to you about proton pump inhibitors, we start with dose and exposure, and we look for a pharmacogenetic influence on the response. Next slide. An important consideration, though, is that there's something in between there, right? Because there's two pieces of the puzzle. There's drug disposition, and then there's biological effect. So it's really nice to be able to split out the pharmacokinetics from the pharmacodynamics. In order to do that, though, you really have to have drug concentrations. I don't see another way around it. You either have to be able to estimate them really robustly based on the dose, or you have to measure them in your patient population. So next slide. That's exactly what we set out to do for a patient of pediatric cardiac surgery patients. And we started out with a pilot study that we had published in 2016, where we took cardiac surgery patients, we extracted the information like covariates and their fentanyl dosing information from the electronic health records. But then we wanted to measure fentanyl levels. So what we did is we scavenged samples from the chemistry lab. So every time a patient was in the hospital and their provider ordered something like a test of their electrolytes, and there was some blood left over, we asked the lab to give us that sample so that we could run it on a multi-drug mass spec assay and measure their fentanyl concentration along with a few other drugs. So this was a successful study. We were able to perform pharmacokinetic modeling as kind of proof of principle. It wasn't guaranteed to work because it was very sparse sampling. It was at random times because, you know, whether or not you need your electrolytes tested has really nothing to do with your fentanyl status. And the electronic health records can be an iffy source for medication data, as I just mentioned about proton pump inhibitors. But we did this, and when we studied this cohort, we got very similar pharmacokinetic parameters to what we saw in the published literature. So we were encouraged by the fact that we could do this in one small patient cohort. Next slide. One of the limitations of that prior study, though, was although it was relatively large, I had more than 100 patients, because the data were so sparse, our confidence intervals were really wide in our PK estimates, and we couldn't really include any covariates. So again, it was kind of proof of principle that this could be done, but we really needed a larger sample size to learn more about fentanyl pharmacokinetics in this patient population. So we wanted to do a bigger study. We wanted to include patients that were included in this cohort from 2012 to 2017 who were exposed to fentanyl. We wanted to have very short list of exclusion criteria, include as many patients as we could. We basically only excluded patients if their surgery was canceled, if for some reason we were missing their fentanyl dosing, if the patient passed away while they were in the hospital, because fentanyl use at end of life care can be a little bit different than what is typically done for patients. And then if they had ECMO support while they were in in their recovery, we also removed them from the cohort because we know that being on the essentially bypass machine changes your drug kinetics in a lot of different ways. We wanted to have this really robust cohort. Next slide, please. But anyway, so the idea was, again, we take remnant samples, we collect your DNA and plasma that was left over from whatever clinical testing was going to be done. We subject that to genotyping, and with a bigger cohort, we'd be able to understand something about pharmacogenetics of fentanyl. We're also going to check fentanyl levels. Next slide. And then we'd also use this electronic health records data to get more information about the patients. Next slide. Next slide. There we go. The daunting thing, though, as we plan to do this bigger study, was we looked back at the timeline from our pilot study. That included 130 patients, and this is the timeline of data, electronic health records data extraction, cleaning, formatting, and analysis. And I really wish that the units of measure on this were months, or ideally weeks, but no, this was years. It was so hard to get the data out, to get it cleaned and formatted. The analysis was the easy part, but it was incredibly time consuming. Next slide. So we found ourselves saying there just must be a better way. Like, this can't be the right way to do this, right? This doesn't seem to be working out. Next slide. So thankfully, one of my collaborators in this work is Lena Choi in our Department of Biostatistics. And she said, you know, we need to solve this problem, not just for fentanyl, but in a generalized way, and not just for Vanderbilt, but in a generalized way, so that we can use electronic health records data for pharmacokinetic studies. Next slide. So Lena worked together to develop this system. And the idea behind it is that we can upcycle real world data. So we don't want to just do this once. We want to do this in a serial fashion so that we can take the real world data, we can do PK/PD analyses, make the dosing better. And then if this is an easy enough process, we can do this over and over again, kind of like quality improvement work, where we continue to refine the model as we learn more and more about our patients. Next slide. Right now, there's lots of barriers to being able to do that. This is a tough hill to climb, as a little person in the red hat shows. But Lena's idea is that if we had reliable algorithms and a standard data process, there'd still be that mountain to climb, but we would be facilitated. It would be a lot easier to get up the mountain so that we could get optimized dosing for children. Next slide, please. So Lena took a modular approach to solving this problem. And there are sort of three levels that we need to think about in being able to use data for analysis. One is data extraction, the next is data processing, and the third is data building. Next slide. So data extraction involves getting the data out of electronic health records. And there are a couple different types of data in electronic health records. Some data are discrete data. They are relatively easy to pull out. So you can picture this as almost like a spreadsheet, like the one that I showed you that showed the dose and the strength and route and all those things for the proton pump inhibitors. If those data are in a table and it's codified, it's easy to pull out. I can pull out, for example, bolus levels or bolus doses of fentanyl that are given, because those are all recorded in medication administration records in the electronic health record. Easy peasy. What's difficult is when you have infusions that are changing moment by moment, and when you have drug doses that are given as outpatients, that you need to extract that information from the electronic health records, like we did, or from the clinical notes, like we did for proton pump inhibitors. There are some programs that do this for us. They tend to be very generalized. So, no, keep going, sorry. Go ahead, Sarah, and click through the animation on this next one. So when you have, what Lena did is she took the ability to take the text out for drug names, and instead of having a generalized approach that tries to pull all the meds out, she built a program called Med Extractor. And the idea of this is that you have a specific drug that you're interested in. In this example she's showing is for lamotrigine. And so for that particular drug, you can specify the parameters within Med Extractor in order to make sure you find the features that you're looking for with the specificity that you need. This essentially allows you to tweak the natural language processing system in order to make it as good as possible for your drug of interest, because what works for Lamictal might not work for tacrolimus. So this is a really powerful tool for getting information out of the EHR. Next slide. The next step is data processing. You can go ahead and click through. The next step, this is once we get all that information out of the electronic health records, you need to format it so everything is together and that we retain the timestamps of everything so we know when doses are changing. Next slide. When we looked at the Met Extractor program that Lena built, I found this really interesting. I think there's an animation on this slide, Sarah, if you want to go ahead and click through that. So first of all, when we looked at just the, so this is for a prescribed medication, prescribed outpatient medications, tacrolimus and lamotrigine. When we looked at e-prescription data, a quarter to a half of the doses were missing, or the dosing changes were missing. So that was really unfortunate. And then the accuracy of that prescription data, thank you, was actually not that good either. So even once we had the information, the stuff in that those discrete dose fields was not very helpful. Next slide, or next click. But when you use the Met Extractor program and she was able to tweak it for the specific drugs, we were able to get comparison to a gold standard data set. We had 95 or 93% accuracy in getting the exact right dose on that time. And that's comparing to having a trained MD read through the medical charts and say what the dose was at that time. Next slide. So the last step in the process is data building. For those of you who do pharmacokinetic analyses, I know that you know that this is not a trivial step, that being able to actually provide the data into the PK software requires some careful steps to make sure that it is formatted in the right way. And so Lena built some programs and scripts to help with that process as well, taking what's been extracted and processed and putting it in a format for PK and PD analysis. Next slide. So now we had a tool to help us do this work, what took us years before. So I'll get to the timeline in just a few minutes, but first, just to lay out, now instead of 130 patients, we have a cohort of 498 patients who are exposed to fentanyl after their cardiac surgery. Next slide. Here are some diagnostic plots for the population PK model, again, using scavenged samples and electronic health records data. They are not perfect, but they do not appear to be biased at this time, so that made us happy. Next slide. And these are our PK parameter estimates. So we report here the original pilot study data, as well as our new data set with several fold more individuals in it. And as you can see, the estimates are really similar, but the standard errors are much tighter because we have that bigger data set. Next slide. Now we had a bigger data set, we were able to look at different covariates to see if they impacted fentanyl clearance in this population. And what we found is, not unexpectedly, things like weight and age were significantly correlated with fentanyl disposition. We also found that the STAT category, which measures the severity and potential morbidity and mortality from your cardiac surgery, was really important. Length of ICU stay also was, and CYP3A5 loss of function alleles, which I'll show you a little bit more about on the next slide. So we know that fentanyl is a CYP3A5 substrate. So this graph shows number of CYP3A5 loss of function alleles. So that 0, you can see it's a relatively small number, even though we had almost 500 kids in the cohort. There were only 9 that were CYP3A5 poor metabolizers, but they had 0, sorry, there were 9 that were normal metabolizers. CYP3A5 is tricky. I always trip it up because it's a little bit, it's more common to have loss of function alleles amongst North American population. So we can see that they had the people with no loss of function alleles, the people who are normal metabolizers, using this current CPIC terminology, they had faster clearance, whereas those who had 2 loss of function alleles, which was the majority of the cohort, they actually had lower clearance of the drug. What's really important in this graph, though, is that we see these modest differences that are statistically significant across the genotype groups, but the variability within the genotype groups is enormous, right? Like, there's lots of other factors that are playing a role in the differences between patients, potentially with much larger impact than CYP3A5. Next slide. So here's what I was talking about in terms of timeline. This is my favorite quote from the manuscript that described this work. is that, before it took over a year, but now it took only about 2 weeks to prepare the final data set with our new system. And then the major time determining step in using the system was data checking by the investigator for potential errors in the system. So what that's saying is Lena would send the files to Sara Van Driest, who took too long to double check all of the data in order to make sure we had everything right. So next slide. What are some of the things that we checked for? What could possibly go wrong? Next slide. We need to look really carefully at all of the covariate data because we were extracting it from the electronic health record to make sure it looked right. And this is a little bit tricky in a pediatric cohort because our age was very broad. We had everyone from 0 to their young 20s years of age. The weights were anything from 1.9 to 138 kilograms, an incredibly large range. And the height also went from 41 to 188 centimeters. These are all as expected for pediatrics, but if you were doing an adult study, some of these would be considered outliers. Next slide. What we did see is that when we did things like checking weight for age, height for age, and a body mass index, we found one error in that our study database actually had weight and height reversed for a patient. So of course, their PK parameters would have been very erroneous, and we were glad to have found that error. Next slide. We also went through all the duplicates, all the outliers, and we went through every single time course. And Sarah, go ahead and click through the animations on this set of slides, or this slide. So in that lower left corner, patient number 1452 and 1036 just show you what we looked at. Diamonds are fentanyl doses. The bars in red are infusions, and then you see some dots that are the fentanyl concentrations. So this is kind of what we were looking for. And those ones at the top right, 1942 and 130.2 are very typical of what we saw, where people had fentanyl doses and then they had high concentrations and then it came down over time. We saw one individual, 1358, had 2 concentrations at the same time that were very different. When we reviewed the data, it turned out one of those had been coded with the wrong date in the study database. But when we went back to our paper logs, we were able to resolve the difference. And then in 1461, there were actually 2 patients that looked like this, where we saw fentanyl dosing and then concentrations that came down, but then it went back up again for no apparent reason. And in both those cases, these patients required emergency dosing at the bedside that was then recorded on a paper log and scanned into the electronic health record. So those data are not available for NLP systems or to be able to view and extract the information. So what we ended up doing in these cases was truncating at the time where we no longer had accurate data. So as it turned out, even reviewing the data manually, I wasn't able to read the dosing accurately enough to be convinced I understood what amounts of fentanyl these patients received. Next slide. So these data validation steps are super important to make sure you have accurate data going into the model because the electronic health record is far from perfect. And so Lena built these data validation steps into the post-extraction workflows in order to prompt users to kind of do these steps. Next slide. So what did we learn from this exercise? Well, we found out, and I think I've demonstrated to you all, that electronic health records can be a source of a large number of data points, and they have the potential to provide some insights for patient populations that are difficult to study, like these children who have had cardiac surgery. But there are numerous pitfalls and a ton of potential errors that can occur. And some of these can be mitigated by really careful review of the data. So there's no population PK at the click of a button. You've got to sit down and really get up to your elbows in understanding the data. Dr. Abernathy from the FDA has described this as data empathy, which I think is a great term, like really understanding where your data come from and what they mean. What the edges are of it that you can trust and what the edges are of it that you need to either review manually or not use or truncate because they're just not reliable. Next slide. So we've taken a look at the electronic health records, some of which think are a beater, some of which I think are just a classic piece of muscle. And I hopefully have given you a good insight into what's under the hood, at least some glimpses of what you can do with electronic health records and some things that can kind of lead you astray. Next slide. Of course, it's really important to recognize the human beings that do all the work to make all this stuff happen. That's my husband who built that pretty motor that I showed in the previous picture. But next slide, perhaps more pertinent to this work, these are the names of the individuals who did heavy lifting in order to get the work done that I've shown. You know, a lot of the work that I've shown has been going on for 10 years or more at Vanderbilt in order to get us to the point where we are today to be able to do these studies more efficiently. So with that, let me stop. I went incredibly quickly, so I anticipate that there's some things I probably went over too fast to be totally clear. So let me take some questions.
Great, thank you very much, Sarah. We do have a couple of questions on the second part. The one being, were you able to assess the contribution of time on cardiac bypass to clearance?
Yeah, cardiac bypass time is one of the variables that we have in basically every individual. And again, in the initial model and the pilot data, it was not significant. In the final model, it was statistically significant, and that's a covariate that we can include. We're always careful. You know, some of the variables are collinear. So things like the STAT score, which tells you the severity of illness, and the cardiopulmonary bypass time are often related. So, you know, you could throw 18 models and overfit the model, and it may make it look a little bit better on paper, but but we're careful in the final model only to include those that are independently helpful, if that makes sense. But yeah, certainly bypass time is an important variable to consider.
David Weinberg asks, can you envision process changes to better enable use of EHR without adding unworkable amounts of time or expense?
Yeah, so I think there's kind of two ways to go about that. One would be, you know, to pressure things like electronic health records vendors. You know, Vanderbilt used to have a homegrown electronic health record system. And then in 2017, we switched to an Epic system. And so, you know, one idea is, you know, for all of us at Epic, with Epic systems to demand, and all those with Cerner to similarly demand that we, you know, sort of free the data. Those efforts have been met with pretty marginal success so far. So I think we should continue to do our best to demand that our systems help us take care of patients better, right? Like, it's not about making life easy, it's about making lives better for our patients. So we need to continue to advocate for that. But the other piece is work like Lena's doing, which will, you know, sort of take what the EHR will give you and create replicable, validated ways in order to ease the process so that it does take hours to days instead of months to years to get these data into the format that you can use. And I think there's some really important sort of methods work and systems work to be done in that space. And I think some of the people on this call are going to help lead that work.
Right, I agree. And there's a couple kind of related questions about processes that might help improve the EHR, and you know, part of it being clinical processes and how we could improve that. You know, for instance, Philip Wilson mentions a process change from a clinical standpoint in how you document dosing. And I know in some of our medication or our record databases that you could find dosing in 2 or 3 different places depending on what unit you're on as well. So having, you know, I think working with Epic, Cerner, and other EHR systems to try to simplify that and make it easier for us to get the data out of would be very important.
And I think super pertinent to our MPRINT network are that we take care of patients, you know, particularly, you know, pregnant women and children are often exposed to drugs for different reasons, in different ways, in different scenarios, and it leads to different charting. And it can even lead to things like I saw with the PPIs, where you don't have the data because sort of the standard process of how the data are exported or the data are processed or whatever, it doesn't work. So, you know, making sure that we are paying attention to our special populations to make these data available specifically for them, because we know a one-size-fits-all approach isn't really going to work. We're going to need to step up to the plate to make sure that we can do right by by pregnant women, children, breastfeeding moms, all of those patient populations, because there's going to be different information that we need. And it's going to be, unfortunately, probably in a different place in the EHR than it is, for a 68-year-old man.
Exactly. I'm going to move back to some of our prior questions. And I know, we're planning some webinars in the upcoming months on informed consent and the bioethics of doing studies in these populations. But could you discuss the informed consent and assent process you used, especially regarding the secondary use language, if planning to incorporate data into a model?
Sure. So I'll just talk about this very briefly, because I think this is a topic that certainly merits more than, sort of 60 seconds at the end of a webinar. It's just really important to get this right. So, in general, both for our biobank studies and for our studies in congenital heart disease patients, if children are old enough to assent to a study, then they're given that opportunity, so that generally aroundish 7 years of age and up, they provide their permission to be included, and they can also decline participation as a older child or as an adolescent. And so they absolutely need to have that in order to move forward. And then parents or guardians are included in the consent process as well, for both young children and for older children. And then when young people reach the age of majority, they're provided the opportunity to consent and make their own choice. So there's a reconsenting process that happens generally at 18 years of age for a typically developing young person. So I look forward to having some more robust discussions about that. But it is really important to make sure that we think about the appropriate way to make sure that children are protected, but also included in research. If we were to say that research is forbidden in children, as has been intermittently done in the way past, that's not good for kids either, because then we're in the darkest providers as to how to care for them.
Great. And unfortunately, I think we're out of time for today. Thank you very much for joining us. And I apologize again to everyone for our technical difficulties in the Zoom environment. That's bound to happen, but I think we had a great discussion, and I look forward to next month's talk. Again, it's February 14th, 2 p.m. Eastern. We'll feature Chambers and Lars Bode talking about drugs and lactation. So thank you.
Yeah, thank you everyone for your patience as I was able to get logged in, and I'll have to find Jim Anton and give him his office back.